Good morning all. In previous video we have discussed regarding the cardiovascular diseases, that is factors responsible for cardiac failure, then prognosis, maternal and other causes of death, then fetal diagnostic factors we had seen, diagnosis of heart disease in pregnancy we had seen, then risk factors of maternal mortality and heart diseases we had seen. So now we will deal with the risk factors for cardiac failure, that is infections like urinary tract infections, dental and respiratory tract infection, anemia, obesity, hypertension, arrhythmias, hyperthyroidism, then drugs like beta mimetics. So the risk factors for cardiac failure are infections, that is urinary tract infection, dental and respiratory tract infections, anemia, obesity, hypertension, arrhythmia, hyperthyroidism, drugs and beta mimetics. The role of anticoagulants. Anticoagulants are indicated in cases with congenital heart diseases, pulmonary hypertension, mechanical heart valve and atrial fibrillation. So the patient is taking warfarin should be discontinued it as soon as pregnancy is diagnosed and to replace it by heparin 5000 units twice daily subcutaneously up to 12th week. Low molecular weight heparin, that is LMWH, can also be used. This is then replaced by warfarin tablets 3 mg daily to be taken at the same time each day and continued up to 36 weeks. Thereafter it is replaced by heparin up to 7 days postpartum. Warfarin is then to be continued. Then unfractioned heparin, that is UFH, LMWH and warfarin therapy do not contraindicate breastfeeding. Then some of the indications for cardiac surgery in pregnancy are failure of medical treatments for intolerable symptoms and intractable cardiac failure. Next we will see the management during labor, that is place of induction. Most patients with cardiac disease go into spontaneous labor and deliver without any difficulty. However, induction may be employed in very selected cases for obstetrical indications, and one should guard against infections and pulmonary edema due to fluid overload. So in labor first stage position, the patient should be in lateral recommended position to minimize the aortocaval compression. Oxygen is to be administered, that is 5 to 6 liters per minute if required. Analgesia in the majority is best given by epidural. Then prophylactic antibiotics against bacterial endocarditis can be given. Then fluid should not be infused more than 75 ml per hour to prevent the pulmonary edema. Careful watch of the pulse and respiratory rate. If the pulse rate exceeds 110 per minute in between uterine contraction, rapid digitalization is done by intravenous digoxin, that is 0.5 mg. Then cardiac monitoring and pulse oximetry can detect arrhythmias and hypoxemia early. Central venous catheter monitoring may be needed in selected cases. Then prophylactic antibiotics for bacterial endocarditis also giving, that is antibiotic prophylaxis during labor and 48 hours after delivery is considered appropriate. This is to prevent bacterial endocarditis. The recommended regimen include intravenous ampicillin 2 gram and gentamicin 1.5 mg per kg, not to exceed 80 mg at the onset or induction of labor, followed by repeat doses, that is 8 hours interval. Then for what are the cases regarding the high risk? So the structural heart diseases, rheumatic heart diseases, cyanotic congenital heart diseases, presence of dental and respiratory tract infections, hypertrophic cardiac myopathy, prosthetic heart valve, prior history of infective endocarditis and cardiac transplant patients are called to be high risk patients. Then we will see regarding the second stage management. So no maternal pushing and tendency to delay in the second stage of labor is to be curtailed by forceps or vendos under pudendal or perineal block anesthesia. Vendos is preferable to forceps as it can be applied without putting the patient in lithotomy position. So vendos is preferred than the forceps. Then intravenous ergometry with the delivery of the anterior shoulder should be withheld to prevent sudden overloading of the heart by the additional blood squeezed out of the uterus. Then its third stage, conventional management is to be followed. That is, slight blood loss is not detrimental, but if it is excess, oxytocin can be given by infusion, and this may be accompanied by aggressive diuretics by IV furosemide. It is better to administer oxytocin in presence to ergometrin in all cases of heart diseases in third stage. Then in place of cesarean section, that is in general, there is no indication of cesarean section for heart diseases. Next, we will move on to cardiac indications for cesarean delivery. If we are doing the cesarean delivery, some of the cardiac indications are, if the mother is having the coarctation of aorta, then aortic dissections or aneurysms, aortopathy with aortic root greater than 4 cm, then warfarin treatment within 2 weeks in coarctation of aorta. Elective cesarean section is indicated to prevent rupture of the aorta or mycotic cerebral aneurysms. The anesthesia should be given by expert anesthetist using either epidural or general anesthesia. Then in puerperium, the patient is to be observed closely for the first 24 hours. Then oxytocin is administered. Then hourly pulse, BP and respirations are recorded. Diuretics may be used if there is volume overload. Breastfeeding is not contraindicated unless there is failure. Anticoagulant therapy is not a contraindication of breastfeeding. So how should manage in contraception period? Steroidal contraception is avoided as it may cause the thromboembolic phenomena. So steroids should be avoided. Then intrauterine device, that is copper IUCD or LNG IUS, is often avoided for fear of infection through, even though WHO permits its use. Then progestin only pills or parenteral progestins are safe and effective. They may cause irregular bleeding, especially if the patient is anticoagulated. Then barrier method of contraceptives, that is condom, is the best. Then sterilization should be considered with the completion of the family at the end of first week in the puerperium under local anesthesia through abdominal route by mini lab technique. If the family tree is completed, sterilization can be performed after the 1 week after the delivery and through the abdominal route in local anesthesia. Mini lap procedure can be done, and if the heart is not well compensated, the husband is advised for the vasectomy. Next, we will see the management of cardiac failure in pregnancy. The principles of management are same as in non-pregnant state also. A cardiologist should be involved. Underlying pathophysiology and the cause of failure must be understood. Then proper position should be given for the mother. Then O2 administration should be given. Then monitoring with ECG and pulse oximetry should be done. Diuretics can be given like furosemide, that is loop diuretic, 40 to 80 mg IV. Anticipatory aggressive diuresis is needed to avoid pulmonary congestion. Mechanical ventilation, that is injection morphine 15 mg IM, digoxin 0.5 mg IM followed by tab digoxin 0.25 mg per oral. Digoxin crosses the placenta and it is excreted in breast milk. And dysarrhythmias, quinidine or electrical cardioversion can be done. Then tachyarrhythmias is there, adenosine 3 to 12 mg IV or DC conversions. Then some of the predictors of adverse maternal outcomes are prior cardiac failure or arrhythmia or transient ischemic attacks, baseline NYHA, NIHA class greater than 2 or associated diagnosis. Then left heart obstruction, mitral valve area less than 2 cm, aortic valve area less than 1.5 cm square, or peak ventricular outflow gradient greater than 30 mmHg by echocardiography. Left ventricular ejection fraction less than 40 cm. So this is regarding the cardiac failure. Then next video we will be dealing with some of the specific heart diseases during pregnancy like rheumatic heart diseases and cyanotic and acyanotic heart diseases. Hope you understood. Please subscribe my channel for more OBG related and nursing related videos. Share to your friends also. Thank you.